So we'll have our next speakers joining us shortly, and we'll also be having Dr. Panda joining us shortly to take few of the questions which were asked during his session. So if we go back to the three sessions so far, we have already covered a very important one uh, of prandial insulin. Then we have discussed something which is not talked about. As a clinician, as someone in the medical college seeing patients, whenever the patients come in groups or whenever we have multiple patients in a single room, we often don't hear the tabooed or a question which is considered as a taboo about the erectile dysfunction or the sexual dysfunction in diabetes. And specifically, this topic was taken up to address those, because sometimes, even in academic forums, this sexual dysfunction or erectile dysfunction, which can be a harbinger for future cardiovascular disease, is often not talked about and maybe kept under the wraps. So that's why this topic was taken up, and we have already discussed regarding this topic, where we have had a neural component, a vascular component, a structural component, and a hormonal component, with the various mechanisms happening at the vascular level, at the level of the endothelium, the various mechanistic processes which have been elucidated in the elaborate talk by Panda sir, which can lead to the erectile dysfunction, and also about the approach. Now, the approach in a patient depends upon the history which is elicited. And often, as I was mentioning previously, that in our busy OPDs, the patients sometimes don't come up with this history. Because again, as I said, it's a taboo. So sometimes they will say that, Dr. Saab, we have something to say, and they will just go in a hushed voice. Their voice will certainly go down, and then the question will be raised, or then the topic will be discussed. And especially if there are lots of people around, then often it gets neglected. This is more so even with the females, though the topic was erectile dysfunction and not, but as a whole in sexual dysfunction, it's often a topic which is not discussed even by the patients themselves. We have talked about the treatment also. Now, there were certain questions regarding it, and I'll just mention them as we go along. But we'll be taking the answers from Panda sir as when he joins. So we had questions from our respected senior and teacher, Dr. Shorajit Bunik sir, about how do you approach a case of erectile dysfunction who is having a good glycemic control. So the approach to a patient of erectile dysfunction in general was discussed in one of the later slides during sir's talk, where the approach with a good history, a good clinical examination, which is addressing all the aspects of the mechanisms or the pathogenesis which we have just discussed, and then discussing the potential therapies, the potential treatment options becomes an important cornerstone of addressing the patient. Now, often erectile dysfunction comes often not in the medicine OPD, but they often go to the psychiatric OPD. And then on further evaluation, the patients are detected to have diabetes. So they probably go with depression, anxiety, and various other sorts of presentations. And then the referral comes to the medicine or the endocrinology department for the glycemic abnormality, which is then detected as a part of the workup, and then the management is initiated. Coming to the other mechanisms, which are the questions which have been asked: how long does it take for improvement in erectile dysfunction in diabetes patients? So there have been a few studies where they have looked at prospectively about the improvement in the symptoms. So there was a 2014 study which talked about improvements in patients with early erectile dysfunction within a period of 4 to 5 years also. So there, but all the patients in that subset were not having diabetes. So those with diabetes, so separately they have not been mentioned in that specific study. And on the specific role of smoking and dyslipidemia in diabetes patients with erectile dysfunction. So as the mechanisms have been highlighted already, that at the endothelial level, the dysfunction which is there with the nitric oxide synthase mechanisms and the role of PDE5 and the role of AGEs. So not just the level of hyperglycemia, but the chronic dysglycemia or the chronic presence of diabetes mellitus or the presence of diabetes mellitus over a long duration itself can lead to changes which can produce changes at the vascular level, which can lead to the thickening, and it can impair the mechanisms which have been already talked about. Also, we know from previous discussions or from the discussion on this topic that the neural component, which can be affected by the duration of diabetes and also by the glycemic control itself, and also some of the medications which are used for its treatment. So we have these various issues when we talk about erectile dysfunction and smoking and the various other parameters of metabolic dysfunction which can contribute to the dysfunction which is happening in our patients. So we have discussed various other questions. So if we have any more questions from the audience on the already discussed topics, they can come up with those.
Yeah, Dr. Bodhayan, this is Dr. Shubham. Since Dr. Panda will be joining in another 5 minutes, he said by 5 minutes he will be joining. So since I have Dr. Shayan Ghosh with me, who is a very renowned endocrinologist from Kolkata. So we had already a session on this prandial insulins. I will just ask Dr. Shayan regarding his experiences with the prandial insulins and which are the prandial insulins that he generally uses, and if there are any issues with regards to cost and compliance as well, and with regards to the side effects or hypoglycemic attacks, what are the experiences of him using the prandial insulin?
Yes, the experience regarding the use of prandial the insulin is that it is preferable to use the insulin analogs in the patient with type 2 diabetes, and especially after during the insulin initiation, the first is to add the basal insulin in the majority of the patients, and after that, even when the fasting sugar is well controlled, then we have to fix the postprandial value. And if there is any spike in the postprandial value, and we have to fix the what is the major meal of the patient and when the major meal is taken. Now we should add the prandial insulin during that time as a basal plus regimen, and we can choose this major meal portion and have to fix the major meal portion and then add a bolus insulin or prandial insulin during that time, and preferably it should be the insulin analogs. And if the patient cannot afford with these insulin analogs, then we can use the regular normal human insulin, regular insulins. And if the advantages of the these analog insulins is the shorter duration of actions, and so that it can be taken just before meal, and especially in the case of the FIAPs, it is already discussed that it can be given after the meal. And also the shorter duration of action may have can reduce the chances of the long-term the hypoglycemia in the long run. And if the blood sugar level is not controlled with a single prandial insulin, then we can increase the time of the injections, that can be increased to a basal bolus regimen, that is 3 time bolus dose or prandial dose, then 1 time longer acting dose. And usually the most of the patient is controlled with this regimen. But for the majority of the patient, it is very much cumbersome to give 4 time injections daily at the home settings. So the premix insulin is preferred in that setting, especially if if their meal pattern is fixed. They are not variable meal pattern. The meal pattern is usually fixed, and the patient then the premix insulin can also be given in the place of this basal bolus regimen, and it is specially to give in the before breakfast and the before dinner time, and to choose the dosage regarding the meal pattern. And the main disadvantage is the titration of the doses and the adjustment or the up titration of the dose. When the blood sugar level is increased in the only the post meal value, then we have to increase the dose, but it will increase the both longer acting and shorter acting dose. So we cannot just increase the short acting dose in a premix insulin. So better to give the basal bolus regimen. If it is not possible for the patient to take this basal bolus regimen, then can give the premix regimen in these settings. Nowadays we the good control with these the analog insulin premix, that is insulin aspart and the degludec combinations, is also going better as per the clinical experience, because the one time giving the insulin aspart and degludec combinations is also helpful to control both the fasting glucose and also the postprandial excursions to some extent, and it is given first time during the major meal of the patients. If it is not, even after giving the single dose of this aspart degludec combinations, if it is not controlled, the other meal portion of the post meal values are high, then we can give the shorter acting insulin analogs 2 times and 1 time aspart and degludec combination, or we can give the 2 time aspart and degludec combination in such settings for the better glycemic control. For the advantages of these degludec and aspart insulin combinations is that basal insulin component is remain in the blood for a long duration of time, and with a very minimal fluctuations and very lower the least chances of nocturnal hypoglycemia. And it is usually most preferred in the Indian settings, because we all know that it is in the most of the patients taking the high carb diet, and the PP, so the glycemic the disbalance is much more common in our Indian settings. So it is most commonly preferred in such settings that come with the combinations of these degludec and the aspart combinations in these settings. Thank you.
Thank you, Dr. Ghosh, for talking on the prandial insulins and highlighting the answers to few of the questions asked. So now is the time for the keynote address. The address we have been looking forward to in this National Cardiometabolic Update 2021. For this keynote address, may I request Dr. A.G. Unnikrishnan to kindly start his deliberation on the topic of insulin 100 not out. Dr. Unnikrishnan is an endocrinologist and CEO of Chelaram Diabetes Institute, Pune, a leading diabetes institute in India, and an IDF certified center for education and excellence in diabetes care. He heads clinical care, research, education, and also oversees a philanthropic rural diabetes care program at the institute. The institute's work in remote communities via mobile diabetes clinics operating in a hub and spoke manner in remote parts of Western India has been widely appreciated. He has published the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide, in addition to his many other publications. He is also the former editor-in-chief and founder editor of the Journal of Thyroid Research and Practice. He is executive editor of Indian Journal of Endocrinology and Metabolism, and he has more than 160 publications in index journals. He has received the Subhash Mukherjee Oration Award of the Endocrine Society of India and the Srivastava Award of the RSSDI, India's largest diabetes society, for his contribution to diabetes in India. He has also received the Jacob Memorial Prize for the Best Patient Care awarded by the CMC Vellore in 1998. He received the Fellowship Award of the RSSDI in 2017 and the Dr. Sam G.P. Moses Oration award by the Diabetes Association of India in 2018. Recently, he received the Diabetes Excellence Award at Digital Diabetes Summit at Hyderabad 2019. May I now request the speaker, Dr. A.G. Unnikrishnan sir, to kindly deliver his talk.
Thank you, Dr. Das Munshi, for that kind introduction. Am I audible?
Yes, sir. You are audible.
I'd like to thank Dr. Shubham Das. I visited Durgapur many years ago and before the pandemic, and I hope to visit you all once better days come to Mother Earth. On that note, let me start by talking about my topic, which is insulin 100 not out. So this is going to be the overview of my talk, and I'm going to talk about 100 years of insulin, innovations in insulin, generation 2 basal insulins, and if you look at the basal insulins, which is where all the innovations are right now, how to differentiate between generation 2 basal insulins which are available. So let's look at 100 years of insulin, and really, it's very well known that the history of diabetes is amazing. From the Ebers Papyrus to the journey of Frederick Banting in Toronto, who actually contributed to the discovery of insulin, to Elliot Jocelyn, who helped us to understand the connections between type 2 diabetes and adiposity, the journey has been fascinating. It was Paul Langerhans who, in 1869, very mysteriously, he discovered certain cells which he called the islet cells scattered in the pancreas. I have read that Paul Langerhans, this was part of his PhD thesis, and the PhD committee asked him, why are you reporting such an insignificant finding? So Paul Langerhans actually, that time the pancreas was not known, insulin was not known. It is said that Paul Langerhans apologized for the discovery of these little cells in the pancreas, which he called islets. The apology for an island later was one of the most important scientific breakthroughs in modern mankind, because diabetes is one of the most important public health diseases. From Langerhans, we go on to Minkowski, Oscar Minkowski, who did pancreatectomy in dogs and induced diabetes. Other scientists kept on thinking about insulin and pancreas, etc., etc., etc. This went on till 1920. And then Banting, Frederick Banting, dropped into the medical school library on Saturday and October 30th. He noted an article by Moses Barron. And on Sunday, October 31st, Banting was sleeping at night, had a eureka moment at 2 a.m. And believe it or not, he got up and wrote down, and these are the notes which he wrote. Diabetes, ligate the pancreatic duct of the dog, keep the dog alive till the acini degenerate, leaving the islets. Try to isolate the internal secretion of this to relieve glycosuria. Thus began the journey of insulin, because in 1921, Banting began his research with BEST. But in May, this started, but in June, he found high casualty rate among the depancreatized and pancreatic duct ligated dogs. So by end of July, he injected chilled pancreatic enzymes in dogs and improved glucose levels. In December 12th, 1921, Collip joined and devised an extraction protocol by use of 90% alcohol. And then in 1921, the form of insulin was obtained for human use. So in 1922, the first boy, Leonard Thompson, was a 14-year-old boy with type 1 diabetes. He was injected with McLeod's extract. The sterile abscess developed, but blood glucose improved. Collip, a scientist, again made a successful better extract, injected Thompson again, and Leonard Thompson became one of the first, indeed the first type 1 diabetes person to partake of insulin. So impact of insulin on treatment of diabetes is phenomenal. Type 1 diabetes has remarkably changed after the discovery of insulin. Before the discovery of insulin, people with type 1 diabetes had a lifespan of less than 3 years, and 2/3 of people, children with type 1 diabetes, died within 1.4 years of diagnosis. And after insulin discovery, survival has increased progressively, and today, near normal longevity is assured in people with type 1 diabetes. In type 2 diabetes, before insulin, there has been poor quality of life, and now we have better quality of life. So let's look at the innovations in insulin. So you had once daily injection, which reduced hypoglycemia, independent of mealtime, reduced weight gain, better adherence. This once a day insulin sort of gave a basal 24 hours insulin throughout the day. And that made it easy to work with oral anti-diabetes drugs, so that once a day basal insulin with oral drugs control sugars. And Glargine was a disruptive innovation because insulin Glargine became the gold standard basal insulin. It had no pronounced peak, a smooth action profile, less inter-individual variability, and 24-hour coverage. This is not to say that other insulins weren't important. Lispro was equally important. Aspart was equally important. Detimir was also important. So each insulin is important in its own way and represents an incremental innovation over the previous insulin. But what I'm going to talk about very quickly is the generation 2 basal insulins and how to address the unmet needs in diabetes management with generation 2 basal insulins. I will be very quick with my presentation, so we will end well before time. But let me now talk about some of the latest updates. So this is a study called the Landmark study. I was also an author in many of the papers in the study. The Landmark study was presented in ADA 2021, and it is the first large-scale longitudinal prospective observational real-world study to investigate the management and complications of type 2 diabetes in India. It was done over a period of 3 years, and what we found is that 4 out of 5 people with type 2 diabetes are uncontrolled in India. Less than 1 in 4 Indians with established type 2 diabetes actually take insulin. The average HbA1c at which insulin is started in India is 9.2. So we are allowing the HbA1c to rise to 8, 8.5, 9, and even 9.2 before we actually are able to prescribe insulin. So both basal insulins as well as prandial insulins as well as premix insulins have been used in several guidelines. But basal insulin is a very simple way to start with once a day insulin, adjust the fasting, fix the fasting, and wait for the postprandial to come down, and also the A1C. Therefore, almost all guidelines, without exception, whether it is the IDF, the ADA, the UK guidelines, the European Society of Cardiology, the Research Society for the Study of Diabetes in India, the Endocrine Society of India, the AAC, the AD, all these guidelines have been unanimous in calling basal insulin a good insulin for initiation and one of the most convenient insulin regimen in people with type 2 diabetes. The starting dose of basal insulin in these guidelines is now set at 0.2 units per kilogram per day. So remember, if your patient is 70 kilos, don't start with 10 units, start with 14 units, because you start with an appropriate weight adjusted dose, and that will help our patients reach target earlier and better. Many scientists now believe that 10 units of basal insulin starting is a good rule of the thumb number, but the starting dose should actually be 0.2 units per kilogram per day. So that brings us to Glargine and other basal insulins. Initially, we had insulin Glargine in 1992 and insulin Detimia. Insulin Glargine, as you can see in this blue line, is virtually peakless, and insulin Detimir is also peakless. Unfortunately, insulin Detimir lasted only for about 12 to 16 hours, and therefore people went in search of a better insulin. And that brought us insulin Degludec, which, as you can see, compared to Glargine, has a much more flatter profile. And that also brought us to Glargine U300, which, like Degludec, has got a flat profile. So generation 2 basal insulins have changed the way we practice because they are truly ultra long acting, last well beyond 24 hours, are injected once a day, have minimal hypoglycemia, minimal weight gain, which means that titration of the dose of these basal insulins is very, very easy. So longer acting, ultra long acting basal insulins, the analogs, the new generation or second generation basal analogs like Glargine U300 and insulin Degludec have overcome the deficiencies of older insulins like NPH. Can you imagine they used to inject NPH as a basal insulin? See the relative insulin effect. It's got a strong, clear peak, but unfortunately, NPH was the only insulin available then. And NPH itself is a wonderful innovation because before that, you didn't even have insulin that could last for 16 hours. You had only regular insulin which could last for 6 to 8 hours. So what I'm trying to say is that do not look at any insulin as truly superior or truly inferior. Every insulin has its own place. And with time, even the good old NPH insulin was an innovation at that time, followed by Glargine U100, Detimia, Degludec, and finally Glargine U300 in schedule of their appearance. If you look at generation 2 basal insulins, whether it is Glargine U300 or Degludec, both show superiority over Glargine U100. On your left, you will see the comparison between Glargine U300 and U100. You see the central line there in the forest plot, and look at all the little green dots. One look at the green dots and you'll find that all the green dots lie on your left. They favor Glargine U300. So in terms of hypoglycemia, Glargine U300 is better. And if you see the overall ranking above, which is for anytime hypoglycemia, and the overall ranking nocturnal hypoglycemia, both these are statistically significant reductions. There was a 19% reduction in overall hypoglycemia and a 25% reduction in nocturnal hypoglycemia with Glargine U300 versus Glargine 100. Similarly, when you compare Degludec versus Glargine 100, the anytime hypoglycemia did not differ, but the nocturnal hypoglycemia significantly lowered by Degludec compared to Glargine U100. Glargine U300 versus Glargine 100 both show a comparable glucose control, and the A1C control is similar. The weight is a little lower with Glargine U300, as you can see, almost half a kilo. And hypoglycemia is also lowering. So you are getting an insulin that lowers the fasting glucose, lowers the HbA1c, minimizes weight gain, and also minimizes hypoglycemia. So indeed, Degludec and Glargine have set the stage for perfect second generation insulin. So the second generation insulins, such as Degludec and Glargine U300, have a stable and prolonged action. They have less glycemic variability. They have effective and sustained glucose control. They have less overall and nocturnal hypos. They are safer during titration. They have minimal weight gain and flexible dosing. Again, I want to highlight that we are talking about basal insulins because they are the highly talked about innovations. Most of the rapid acting insulins are similar. Glulisine is similar to Lispro, is similar to Aspart. Maybe faster acting Aspart is a little more superior to the other prandial insulins. But when you look at basal insulins, Glargine is a product which has changed the management of diabetes. So there are two basal insulins available today, the generation 2 basal insulins. And 100 years after the discovery of insulin, isn't it amazing that we have two amazing insulins and we have to choose between these two good insulins? Fantastic insulins in their own right. Let's look at the data. Before we understand it, at 100 years, insulin is now experimenting with different modes of action. While Degludec has got zinc and phenol, which allow the insulin to quickly form a hexamer, and the phenol allows it to diffuse and dissolve. The zinc allows it to monomers very slowly. And once it dissolves, because of the fatty chain, it stays in the blood for a long period of time. So very novel mechanism of action. And similarly, Glargine U300 also has a novel mechanism. It packs the insulin in a lower surface area because at a lower pH, it crystallizes, precipitates amorphously, creating a subcutaneous depot, and this active 21A human insulin forms and is released into the circulation. So this was a bright study, a very bright study, because it was very cleverly designed, I must say. It's a multi-center, open-labeled, 1:1 randomized trial in people with type 2 diabetes who are adults. So after a 2-week screening period, both groups were studied. They were randomized into Glargine U300 at 0.2 units per kg per day as per label, and Degludec 10 units as per label. So after starting, the first 12 weeks were titration, and the next 13 to 24 weeks were maintenance. And after the 24 weeks, the post-treatment phase was started. The primary endpoint was assessed somewhere here at the end of the 24-week treatment period. And you'll see that both Glargine and Degludec had identical HbA1c reduction during the titration period and in the maintenance period. But you will find that if you look at the incidence of hypoglycemia, some of the data seems to favor Glargine U300. If you look at the incidence of hypoglycemia, as you can see in these circles here, and the incidence of hypoglycemia event and the new hypoglycemias and the total events, you can see both seem to be better with Glargine U300, whether you apply the 70 milligrams cutoff and the 54 milligrams cutoff. Again, I'm not trying to sound biased here, and these two insulins, the Degludec and Glargine U100, are both wonderful insulins. We are just trying to show some nuances in the interpretation of the data in the BRIGHT study, which shows that hypoglycemia during the titration phase especially may be minimized if you use Glargine U300. And you can see that nocturnal hypoglycemia also reduced. What you will also find that the variability is a little less with Glargine U300 compared to Degludec. So Degludec, a little more variability. And then you had the real world evidence. They took people with type 1 diabetes who were switched from first generation basal insulin to either Glargine U300 or Degludec 100 within 24 months, and they were studied. The primary endpoint was a time in range. They took people with type 1 diabetes of 45 years, duration of type 1 diabetes more than 3 years, and they took people with A1C above 7.5%. As you know, the time in range is obtained from a continuous glucose monitor. And you also are aware that a continuous glucose monitor checks blood sugar about 100 times or more per day. The Freestyle Libre Pro checks your blood sugar 4 times every hour, which means about 96 readings an hour. And the number of readings or the proportion of time that is spent between 70 to 180 is called time in range. What they found is that if you take the full day treatment period, the time in range of Degludec and Glargine U300 was similar. If you take the nighttime period also, there were some differences favoring Glargine U300. You can see that the time in range was slightly higher in the Glargine U300 group. But I don't want to sound biased. Degludec is also a wonderful insulin. So you had regular insulin, you had NPH. Some of us who are old here, including me, I'm 51, remember Lente, Ultra Lente, Glargine, Lispro, Aspart, Detimia, Degludec, Glargine U300. The second generation novel insulins have less glycemic variability, less anytime hypo during titration, less nocturnal hypo during titration, better time in range, and lesser weight gain. So there are several advantages of novel devices, and an insulin pen with a simple operation can always help. And a good cartridge and a good device always helps people. So friends, Generation 2, I'd like to conclude by saying that Generation 2 basal insulins have an array of advantages over Generation 1. Glargine U300 and Degludec are wonderful insulins. Glargine U300 may have an edge, and newer devices help. I want to summarize by just thinking of Frederick Banting, Charles Best, Collip, and MacLeod. They must have been wonderfully satisfied when they discovered insulin. But now when they see where insulin is going, looking at Aspart, Glulicine, Lispro, Glargine, Detimia, Degludec, Glargine U300, the combination of liraglutide and Degludec, the combination of lixisenatide and Glargine, the once in a week injection dulaglutide, the GLP-1s, the peptide in a pill, the insulin pumps, the artificial pancreas, the bionic pancreas, which gives both insulin and glucagon. I'm sure that the look of satisfaction on Charles Best, Frederick Banting, MacLeod, and Collip must be now a different look. They must be astonished, and they must be thinking in their graves what insulin began with and where insulin has reached. Kahan ja rahe the aur kahan aa gaye hum. So insulin was just a way to make children with type 1 diabetes live longer. Now you have insulins which can be personalized to improve the care of people with type 1 diabetes and type 2 diabetes. Indeed, general diabetes better. Friends, it has been an absolute pleasure talking to you on this novel and interesting topic. And thank you so much for listening to me.
Thank you, Unnikrishnan sir, for giving us such an enlightening talk. As always, you have simplified the complex concepts and taking us through this journey of the century of insulin. It's really a learning experience for all of us who have been listening to you over years, and also again today. Thank you, sir.
Thank you.
There are a few questions in the chat box, sir. If you'd like to take them up.
Yes, happy to take. So the first question is, in hospitalized patient, since we are on a time lash to reduce blood sugar levels, many a time we can't wait for titration. How do we address such an issue? By Dr. Chaudhary, a very valid issue, because to titrate Degludec or Glargine U300, you have to wait every 3 days and then increase. So my favorite insulin, basal insulin for in-hospital use is a good old Glargine U100. But increasingly, studies have shown that both Glargine U300 and Degludec can be used in the in-hospital setting, and daily titration can be done. But I must thank Dr. Chaudhary for that question. And I agree that in hospital setting, basal bolus insulin, the traditional Glargine U100 is a better choice along with prandial insulin. Next question is Glargine U100 and U300. Is there any particular profile? Asked Dr. Som. So I think it's only the affordability. If everybody could afford, I would give Glargine U300, but affordability is important. So the key aspect is affordability. Otherwise, I don't think there's anything to choose between. Glargine U300 is a better insulin. Its third question is, what is the maximal dose till which we can prescribe insulin? Glargine, Dr. Rajrishi Mitra. So Dr. Rajrishi, very interesting question, Dr. Rajrishi, because insulin traditionally, one of the earlier definitions, the unit of insulin was defined as, in some studies, in early animal studies, once you inject insulin, you have glycogenesis, glucose forms glycogen. So glycogenesis in the rat diaphragm, and the amount to which the rat diaphragm would become thicker after insulin, that was used to quantify units initially. So units are just numbers. So there is no limit to the number. In general, you can use any amount of insulin to control the blood sugar, including Glargine U300. But I understand the question because Dr. Mitra is asking, because giving, say, 200 units of Glargine U300 can be very expensive. So if it comes to that, it's better to go for a more economical insulin if cost considerations are there. Many doctors have asked me, what is the maximum insulin I have given? I have given to a patient more than 1,000 units once. That patient had autoimmune insulin resistance. Paradoxically, we gave steroids and the insulin resistance got better. The second patient, again, had severe, probably genetic insulin resistance with a minimal, not gross obesity, severe obesity, but moderate to severe obesity. I gave 600 units of insulin. And then after bariatric surgery, the 600 units became 200 units. So there's no end to the units of insulin, but on an average, most people require about 15 to 25 units of insulin. Final question by Dr. Basu is that in pregnant ladies, which insulin is your choice? In pregnant ladies, my long-acting insulin choice is Detemir, followed by Glargine. Of course, you can use Glargine, but Detemir is the number one choice. And in pregnant ladies, my number one rapid-acting insulin choice is Aspart, either the fasting Aspart or the ordinary Aspart injection, but Lispro can also be used. So this is my choice in pregnant women, but this is not to say that Glargine cannot be used in pregnancy. Many times patients on Glargine, if they are well controlled, you can continue them on Glargine, and where Detemir has not been enough, I have given Glargine. I hope I have answered all the questions in the chat box.
Yes, sir. All the questions in the chat box have been answered perfectly, sir. Thank you, sir.
Thank you.
And we will be looking forward to your help and guidance in future upcoming programs also. Thank you once again from the audience.
Thank you, and good wishes to all my colleagues, and stay well, stay happy. Greetings.
Thank you, sir. Thank you, Dr. Unnikrishnan, sir. I'll just take a moment to thank you from the core of my heart. It has been always a pleasure listening to you. And I had the privilege to attend your conference in 2019, just before the pandemic, I guess. So after that, I'm listening to you. So next time I'll be expecting you over at Durgapur and meet all of us physically.
Happy to come to Durgapur.
Thank you, sir. Thank you so much.
Thank you.